first talk is about the video assisted course GATT in different situations by Shikha Gupta, and she has to go to Delhi also. That's fine, and it's already first topic.
So we're talking about GATT in different situations. So the shift has been there towards the MIGS over the last few years, and when we look at the IRIS registry, we see that trabeculectomy and GDDs, they are being replaced by MIGS, even for the routine cataract surgery patients, and even the non-specialists are performing these surgeries because it is safe, minimally invasive. The conjunctiva and the sclera, they remain naive for the future surgeries, and the bleb-related complications are circumvented. So, but whom to perform, which patients to perform this surgery is important. So patients with glaucoma should have angles amenable to dissection with clear cornea. And the primary dysfunction should be at the level of trabecular meshwork. If you're expecting collector channel dysfunction, then better not to perform this surgery. The patient should not be very high IOP patient. They should be controlled or borderline controlled on medications. We can also do the surgeries in failing or failed trap patients and in primary congenital glaucoma patients. So when we do the surgery, it's important that we shift the patient's head so that nasal angle can be maximally visualized, and shift the microscope also down around 30 degrees so that the better visualization can take place. So this surgery can also be performed in primary congenital glaucomas with hazy cornea once we are clear with the anatomy. And to help us with that, we have published some techniques like external jugular vein compression, where it causes reflux of the blood in the Schlemm's canal and helps us delineate the Schlemm's canal in a better manner. Or we can also use dye-assisted visualization like trypan blue and ICG dye. And when the other end of the suture is retrieved, we can actually go about. So even in these corneas where we previously were doing only combined trap plus trap, we now have resorted to the MIGS surgeries. So in using aqueous angiography, we have seen that the primary congenital glaucoma patients, they have dysfunctional aqueous outflow channels which get recovered using MIGS. These are the normal patients that we see. So this is the aqueous outflow channels in normal cataract patients. So in congenital glaucoma, there is a dysfunction which gets relieved after the surgery. And this is the pre and post. This is a patient, these are pre-patients of all our PCG patients. And there was almost no flow before the surgery. And post-surgery, when we again do an aqueous angiography, we can see increased outflow in the sectors where it was not seen. So the surgery really helps restore the aqueous channels in a timely manner. So other than that, we can also take use of AIOSMT in defining whether with the suture we are going in the right plane. So this is the inverted angstrom sign, where the tip of the A is actually the suture within the Schlemm's canal, which can help us. And we can use ICG dye, external jugular vein, and to delineate the Schlemm's canal in a better way. So we have recently published that GATT can be done as a first-line therapy in primary congenital glaucoma. This is yet to come online, but it's been accepted. So the results are really wonderful if we look at PCG patients, and almost 90% patients, they achieve success at 1 year with this technique. So when we looked at our outcomes, this is a randomized control trial with 180-degree versus 360-degree GATT in primary congenital glaucoma. This has also been recently published in American Journal of Ophthalmology. We found that the 360-degree GATT patients did better than 180 degrees. And in terms of better lowering of IOP, decreased need for surgical intervention, as well as reduced need for medications. So I think that's mine. So 360-degree fared much better than the 180 degrees in primary congenital glaucoma group, and now we are resorting to 360-degree treatment in these patients. So even when we looked at the CDR reversal, we could find that the post-operative reversal was better with the 360-degree group compared to the 180 group, which did not experience reversal with the surgery. So this is one of the optic discs showing reversal post-360-degree GATT. The GATT can also be done in some refractory cases. This is an example in an NVG-I, where it was, the IOPs were 30, 38 on maximum medications, and we didn't really want to do TRAB at this stage and wanted to wait after this MIGS can be done. So we attempted the MIGS. So we have had 4 such patients, and the results are really good over the last 1 year. So we tried to break, after intracameral Avastin was given 48 hours before, we did this goniotomy, nasal goniotomy, which resulted in a lot of bleeding, and therefore we used this irrigating cannula, which helped us clear off the blood, and we could actually cannulate the Schlemm's canal and achieve the 360-degree cannulation. And the IOP loading, once we are done with that, it leads to the falling back of the iris automatically, and they have to be given pilocarpine for some time, and then they don't really go back again to form the synechiae. So in this case, 180 degree was done here, and then the surgery was closed. So in angle closure glaucoma also, we have already shown that incisional goniotomy plays a huge role with phacoemulsification in these eyes, in lowering of the IOPs much more than phacoemulsification alone in terms of reduction in the number of medications, as well as a reduction in the mean IOP. So this is a patient where we did only goniotomy in PACG eye, and we can see this is a pre-surgery, and this is post-goniotomy without lens extraction in one of the eyes, and we can see that actually, even with the goniotomy without lens extraction, it leads to an increase in the aqueous outflow channels post-surgery. So even in eyes with post-trab where they are needing medications, this surgery can be used as a salvage surgery rather than going for a re-trab when even the needling is not working. So we can extract the lens along with doing a MIGS, and it does show good results. So recently we've also published a case, a series on GATT in advanced pigmentary glaucoma, and we compared these patients with our TRAP patients in advanced pigmentary glaucoma, and we saw that the results were equivalent. So the number of medications that they were on and IOP was almost similar in the two groups. This was a case report which has been recently published in ophthalmology, where we saw that it also helps the GATT surgery. This is a patient with severe KPs and pigments in the AC with pigmentary glaucoma. And this is the first day post-op that the GATT surgery, because we are actually de-roofing the Schlemm's canal, it also helps in the outflux of the pigments through this route and leads to miraculous disappearance of the keretic precipitates. And of course, then it will also help in lowering of the IOP in the post-operative period. This series we have already compiled, that GATT can also be used. I think I can take some more time as we have less speakers. Thank you, sir. So GATT can also be used when we compared with the results in vitrectomized eyes as vis-a-vis glaucoma drainage device. We saw that the results of GATT were almost similar in IOP lowering and number of AGMs, but the complications were severely decreased. And therefore, so this is the IOP at 1 year. In GDD, it was a little higher compared to this group. And the vision was definitely better in the GATT group. So it can be replaced in those cases where the angle is accessible. Again, this is the emulsified oil bubbles pre-operatively. Post-operatively, we can see the incision without now the oil bubbles are there. So two factors lead to disappearance of oil. Of course, one is we are doing surgery and we are irrigating the anterior chamber and aspirating the oil bubbles. But also they may be outflowing through the new tract and the Schlemm's canal that we have just created. So this was one case. We don't have enough data on this, but this was a silicone oil-filled eye with very, very high IOP 3 weeks into the surgery, and IOPs were not coming down. So we thought that as a interim measure, maybe we can try this, because since oil was already there, it could have led to failure of any surgery that we planned, and oil was not to be removed by the retinal surgeons at this point of time. So we planned an interim GATT in the meantime, and we could successfully achieve the cannulation and the rupture of the Schlemm's canal in this patient. The only problem was the oil kept on coming from behind, which we had to aspirate and keep aspirating till the end. And even on day 1, some oil bubbles. So we can already see oil bubble starting to come up through the gap there, and we are trying to aspirate the oil bubbles. But the patient did had a satisfactory IOP control, though with medication, and he's doing well. At least he's not on mannitol and being admitted in the hospital. So even in complicated scenarios, I want to say, where we did not envisage before that we could do this, we can try this surgery in some of our complicated patients. So now these are the Western data that the surgery is effective also in pseudoexfoliation glaucoma, uveitic glaucoma, and steroid-induced glaucoma. So most of us are now doing, it's simple. We just have to take care that the bleeding doesn't occur intraoperatively. We have to close under high pressure, give pilocarpine in the post-operative period, and give him proper positioning so that the bleeding doesn't accumulate in the recently created channel, and the results are wonderful. And of course, they can be upped up with further surgeries if required in future. Thank you very much for patient listening.
Thanks, Shikha, for
Nice presentation. Thank you.
thank